Good afternoon. It's a pleasure to be here at the CID conference, and I must congratulate the entire team for such a wonderful day. I spoke on secondary diabetes. We have heard the standard classification of type 1 and type 2 and gestational diabetes, but this is one area where we know less and we need to work more in finding out the cause, because unless you find the cause, the hyperglycemia doesn't get corrected. When do you suspect secondary diabetes? When the sugars are very well controlled in the patient and suddenly they go out of control, suspect secondary diabetes. Or you do your best to optimize with the best of drugs and with your entire paraphernalia of anti-diabetic management, and yet the sugars are high, then you suspect secondary diabetes. Secondary diabetes is basically, in most cases, an alteration of the counter-regulatory hormones, and therefore the postprandial hyperglycemia is usually high. That's when you have to suspect if it cannot be managed with the normal course of drugs. Pancreatic diabetes is also known as type 3 diabetes. So, in chronic relapsing pancreatitis or in genetic origin pancreatic disease like cystic fibrosis or hemochromatosis, or in India a fibrocalculous pancreatic diabetes must have an exocrine dysfunction as well, in addition to the hyperglycemia. If you see a young boy, lean, and then he has recurrent abdominal pain and oily stools, especially coming from the south, think of FCPD. FCPD is very common in India, and therefore we have to recognize it. The endocrine dysfunctions which give rise to hyperglycemia are many, but the common ones are Cushing's disease, which have a special phenotype of moon faces, of a buffalo hump, acromegaly, which have large hands, large peripheries, hanging forehead, and a prognathism, and thyrotoxicosis, where there is a goiter, which all these can disrupt the sugars. Another type where the phenotype has changed is in PCOS, where you see hirsutism and apoplexy of the scalp hair, and that leads you to another endocrine dysfunction of the ovary, where patients are given actually OCPs which further perpetuate, and this is a forerunner of type 2 diabetes. There are certain drugs as well which increase or produce secondary diabetes. Diuretics and beta blockers have to be taken in large quantities, and so they are not very common, but post-transplantation drugs, corticosteroids, patients on antipsychotic treatment, and also those who are on anti-HIV treatment can produce secondary diabetes. To summarize, secondary diabetes has to be kept in mind. It has to be investigated well, look for clinical signs, and the hyperglycemia cannot get corrected till you treat the cause. Thank you very much.